Ready?
We're good to go.
Okay. Yeah, we have to hear Alexa's voice there. So good morning, and thank you for spending I guess it's the middle of some people's morning, but the early morning for some people. I'm Jean Hayward. I'm a pediatric neurologist, and today we're going to talk about seizures, how to evaluate and treat them in children and adolescents. To disclose, there are no disclosures, and as mentioned earlier, we are accredited by the Accreditation Council for Continuing Medical Education, and you'll get your CMEs, hopefully. So first of all, when you're thinking about epilepsy, you have to say to yourself, what is a seizure? And it's important to realize that not everything that looks like a seizure really is a seizure. Seizures are a clinical expression of some type of abnormal neuronal discharge from the cerebral cortex. They're usually intermittent and self-limited, often quite short, which is what makes the diagnosis difficult, because it's something that's usually happened already, it's past, and you're trying to scrabble to figure out what that was. Seizures are often have clinical manifestations, but they can be subtle, and there are subclinical seizures where there is not a clinical expression noted that any of us can at least see, and the patient may be describing something that they feel. There are seizures that are acute or symptomatic that are provoked, and these often occur in close association with some sort of illness and or a brain insult. Such as getting whacked on the head with a baseball bat and then having a spell of eye rolling up and stiffening and falling to the ground. That would be pretty obvious. And an unprovoked seizure can occur without any provocation, so no fever, no trauma, no ingestion, that sort of thing. Epilepsy is the state of recurring disposition to seizures. So if you have one event, it's not epilepsy. If you have two or more unprovoked seizures, this is the definition of epilepsy. Epilepsy is pretty common in pediatrics. There's anywhere from 0.5 to 8 kids per 1,000 person years that have epilepsy. If you look to see what happens to these children, they can outgrow their epilepsy, fortunately. Anywhere up to 1% of children will have a single febrile seizure, and 3 to 5% of children will have a febrile seizure less than age 5. Of those children who have febrile seizures, 30% will have more than one febrile seizure, and that is predicted by how young the child is and with the other coexisting risk factors. And then of those children who have a febrile seizure, only 3 to 6% of them actually go on to develop epilepsy. So febrile seizures are very common, but the number of children who have febrile seizures who go on to develop epilepsy for some duration of time is relatively small. And that's important because parents obviously are quite worried about their kids having a febrile seizure and what that means for the future, and so you can reassure them. There are many types of epilepsy, and the number of charts that delineate the organization of the classification of epilepsy over the years have been many. The charts are usually quite large, confusing, and look like a family tree of somebody from the British royalty, I think. But in any case, epilepsy can be classified by the seizure type, the epilepsy type, or an epilepsy syndrome. As genetics progresses, that is also becoming a fourth category in types of epilepsy, because as we are getting better and better at using genetic testing to tell us about genes that make us prone to seizures, then that becomes another category in this list, but I have not included that this time. So seizure types can be as simple as a focal seizure. You can have jerking of an arm or a leg with or without impaired consciousness. You can have a motor event. You can also have sensory events where you feel tingling, or have autonomic events where you have vomiting. And these can either progress or not progress to a bigger seizure with generalized tonic-clonic motor activity and loss of consciousness. Generalized seizures, on the other hand, originate and spread rapidly to involve bilateral networks in the brain and often involve loss of awareness. Doesn't necessarily mean fall to the ground, but loss of awareness. So maybe unable to react to your environment might be a way to categorize loss of awareness. And then there are seizures that have an unknown etiology in that they have they can have bilateral or unilateral representation as to the cause, and yet what you see is a very characteristic bilateral movement. And some seizures are unclassified, although again, as genetic testing becomes better, I think that the number of children that are who have unclassified epilepsies will significantly fall. If you go with epilepsy syndromes as a way to classify things, that sometimes helps you, I think, a little bit more in that you can look at the syndromes that come particularly with age and be better at sort of guessing what this kid might have. So there's neonatal seizures that some of which can be benign. There are familial benign neonatal seizures, so asking the family history is key. There are not so benign neonatal seizures that include early myoclonic epilepsy and Otohara syndrome, which are devastating progressive newborn epilepsies. And then in children less than 2 years of age, as I mentioned previously, there are febrile seizures, and these are relatively common. There are syndromes called febrile seizures plus, where there are children who have seizures with fever, but also without. There's a very rare epilepsy of infancy with migrating focal seizures, where the child will have a seizure on one side and then the other. West syndrome is another name for infantile spasms. And this is another important to recognize epilepsy in the first year of life, and I'll touch on that a little bit later. Myoclonic epilepsy I mentioned earlier, and then there's Dravet syndrome, which is also a devastating newborn epilepsy, which has become relatively well characterized genetically at this time. So if you're classifying the epilepsy syndromes, you can think about the age. So we talked about the newborn and infantile ones previously. The ones that occur in childhood would include the febrile seizures, benign occipital epilepsy, which has a very prominent autonomic component. So these children very often vomit as a manifestation of their epilepsy, which is obviously a little strange, but worth remembering. There is a benign epilepsy with centrotemporal spikes. These kids have a very strikingly busy abnormal EEG, and yet they mostly are having seizures at night. And so again, a relatively common epilepsy, and so worth recognizing and treated specifically for that epilepsy. So once you've got the diagnosis, you know sort of what to tell the parents and how to treat them. Childhood absence epilepsy is very, very common in terms of all these other relatively rare epilepsies. And these are children who stop and stare and have automatisms. They smack their lips, they blink their eyes, they fumble with their fingers, and then they're back. And sometimes these kids are actually picked up by the teachers. Occurs in school-age kids, very often preschool and kindergarten age kids. And so the teacher may have noticed that the kid didn't answer when they were called on or something like that. And then as you get to the teen and on into adulthood, epilepsies, the most important one to recognize is juvenile myoclonic epilepsy, which has a very strong familial history and does not go into remission in 80% of the kids. So important to diagnose because you really need to get the family and the child on board with, this is a long-term plan here. Let's see. So when you're seeing someone in the clinic and they're coming in and saying, well, there's this funny episode, you're dealing with second or third or fourth hand information, unfortunately, and you try and get as much information as you can. Very often you may need to actually reach out to who was there. Did the teacher see it? Was there a classmate who saw it? The friend's mother, that sort of stuff. So it's worth, going as much as you can to get the information. In the day of cell phones, someone may have actually taken a video, God forbid, but as we all know, it happens all the time. You want to know what the circumstances of the event were. Had there been medications given? Was the child sick? Is there substance use or abuse or exposure a possibility? Certainly in the days of fentanyl, we want to make sure that there was not exposure to fentanyl, which is unfortunately everywhere. And then if they've been to the emergency room, what did those labs show? What was the glucose? Hopefully they checked a sodium. Hopefully they checked a tox screen. I mentioned the family history, which is very, very important. And then has there been a prior event? Is this something that happened last year under maybe a different circumstance, but is this nonetheless a very similar kind of event? And does the child have any risk for seizures? Namely, does the child have any evidence or history of brain injury? It has cerebral palsy, developmental delay, genetic syndromes, that sort of stuff. This is a lightning bolt hitting the hills of near Seattle, where my son actually studies lightning. And then there are not great tests to help you with the retrospective diagnosis of was it a seizure, but we still do them because, you know, we all like tests. So an EEG is where the money is. If you get a sleep-deprived EEG, you might actually get your diagnosis. The reason we do sleep deprivation is to get the kid to go to sleep. And so you need a cooperative family, so someone who will keep the kid up till midnight, get them up at 4 or 5 a.m. So I usually recommend movie night with lots of popcorn, and bring them immediately to the EEG lab for the first test in the morning, where someone comes with them. So there's two people, one adult driving the car and the other one keeping the kid awake, because we all know that once you pop your kid into the car seat, they tend to go to sleep. And if you can get the family to cooperate, you should be able to first time easily get a sleep-deprived EEG, where the child goes to sleep. So that's the whole point of the sleep deprivation, is to get the child to sleep during the EEG. The reason for sleep is it turns out that our brains are more likely to make abnormal brain discharges as we are falling into early and the beginning of deeper sleep. And so that's what we're looking for. We're looking for either a localizing sharp wave or spike, or a burst of abnormal brain activity to tell us, you know, what this condition might be. MRIs or CT scans, preferably MRI, are generally done as well, although they're rarely do you find something that surprises you. So the chance of a child having a single seizure and actually having a brain tumor is, without any other symptoms, is not necessarily that high. We prefer MRIs because there's no radiation involved. And we typically do non-contrast MRIs for kids, and only go back and do contrast if we actually found something that warrants contrast administration. For younger kids, you can get the MRI done often without sedation, without anesthesia, if you have that cooperative family who will bring the kid in completely exhausted, sleep deprived, wrap them up in their favorite blankie, and have them get into the scanner with a cooperative technician who's willing to take the time to get it done. If there is a seizure in an older kid, so you may have to report, just like in an adult, you may have to report to the public health department or to the DMV. And so it's worth knowing what your local rules are. I've got a couple listed here, and they vary tremendously from state to state as to what is required and who you send the report to and that sort of thing. So it is it's important to remember to do that, and to not assume that the emergency room sent through a notification, because I have to say, in my experience here, they rarely have done that. So again, common seizures by age, which is an easy way to think of things. So we'll skip the newborns, but in the first year of life, we have the infantile spasms, which are very important to diagnose because of their grave outcome. Under 5 years of age, we see lots of kids with febrile seizures, and these are not usually treated with daily medication. The petit mal epilepsy kids are the kids who stop, stare, and blank out, usually for less than 20 seconds. They don't fall to the ground. They maintain posture and even maintain walking or swimming if they happen to be doing that. Starting at age 3, partial onset seizures, partial complex epilepsies can start. And after age 11, we see the juvenile myoclonic epilepsy kids pop in associated with the onset of puberty. So girls first and boys second. And after age 9, you can see atypical petit mal epilepsy occur, where kids, again, will stop and stare, but they also are prone to grand mal seizures, which the younger kids are typically not. So were you to actually be there when a child had a seizure, or you want to advise to the family or the school how to provide first aid for a child having a seizure, it's important to at least have something to tell them. The Epilepsy Society of your local state, so for me, Northern California, and there is a National Epilepsy Society, have good information on their websites. and have little videos of how to position the patient. We typically recommend that children be rolled on their side in a rescue position, which is the lower arm is raised above so the head can rest on it, and the upper knee is flexed and rolled the hips forwards. The knee is touching the ground. This is important because, at least for kids, they often vomit after a seizure. And so you don't want them lying flat on their back. You want them on their side so that they can vomit and not aspirate. Do not put anything in their mouth. It's really important to tell this to everybody, just because there is an old wives' tale rolling around that says that, if someone has a seizure, you need to immediately get something in their mouth so they won't swallow their tongue, which, as we all know, is attached to their jaw and so can't be swallowed. But I've seen many a kid with injured lips and teeth from someone trying to get their mouth open with some implement. If you can, to observe the time of onset of the seizure and the patient's condition. That includes eyes open, eyes closed, and are they hot, et cetera, et cetera. I always recommend that families call for help if they're not accustomed to their child having recurrent seizures, and to remember to open the front door, only because, at least around here, if you call 911 and they show up, and no one answers the door, they will break it down, and you don't really want that cost of repair. If the seizure lasts more than 5 minutes, then we have rescue meds. And for children who are prone to recurrent febrile seizures, we do prescribe a rescue medication for those kids. It comes as either a rectal diazepam or a nasal midazolam dosing. And for older kids who are out and about in the community, we used to put metal earth bracelets on them, but now that everybody has a cell phone, you can show them how to use your cell phone medical ID information, which is, at least in the iPhones, is under the emergency tab in the bottom left. And if nobody knows where that is, you should be able to get a teenager to help you figure it out.
I found this on the web.
Oh God, Siri just found that on the web. At home, the bed should be away from the wall, because if a child has a seizure asleep, they can have a tonic-clonic seizure that moves them to wedge themselves between the bed and the wall, and that can lead to suffocation, which unfortunately does happen. I recommend no top bunks for kids with seizures. And really, the most important thing is to have constant supervision around and near water. The #1 cause of death for people with epilepsy is drowning, unfortunately, which you would think we wouldn't see in this day and age, but it is important. And I include life jackets for people with epilepsy who are out on boats or even in the ocean, which for the surfers here in California is a big issue. Because if you do have a seizure and fall off a boat, you're gonna sink, at least temporarily. And life jackets both keep you afloat and have a handle to allow someone to haul you, at least to some degree of safety. And then other caretakers, including school and daycare, should be notified, of course. Many schools have a seizure action plan that you can fill out, and the family can obtain from the school, or you can get one online from the Epilepsy Society as well. So you've decided that the patient has some type of seizure, and now you want to decide what kind of medication to prescribe for them. As I mentioned previously, for febrile seizures, which is defined as 6 months to a 6-year-old child with a temperature greater than 101.5, generally a generalized and non-focal seizure, then we don't necessarily give those people medications to take daily. Remind the family that early treatment of the fever doesn't generally work. So even though if your child has a febrile seizure and you take them to the emergency room, the first thing the ER will say is, "Did you give them Tylenol?" But the answer really should be, "How high was the fever?" Because giving Tylenol doesn't necessarily prevent the sudden rise of the fever, which is what leads to the seizure occurring. You can prevent some febrile illnesses, as we all know, by giving vaccinations. So I strongly emphasize making sure that the young kids particularly have all their vaccinations. And I guess COVID is now on this list, theoretically. I do recommend that they separate the live virus vaccines at the first year of age and give the MMR separately from the varicella. This has been shown to have a beneficial effect on the frequency of febrile seizures, and that the peak of the fever when the vaccines are separated is lower than the peak of the fever when they're given together. And again, for children who have recurrent febrile seizures, we do recommend that they have some type of rescue medication at home. The family should know that the school or a preschool may or may not administer this, so that if they want a dose to have at the school, they should first find out if they're going to actually give it. I mentioned infantile spasms. These are rare, but really important to diagnose seizures. The children have a sudden and repetitive either flexion or extension of the body and the arms and legs. Often, because the children are young, around 6 months of age, they look like they're having colic. And the family, is thinking it's some sort of gastrointestinal kind of event. These kids can have usually have had repetitive events by the time you see them. So they've had several spells at least. They typically occur upon awakening, so that's an important thing to ask about. The child's just waking up from a nap and then with the eyes wide open has these repetitive flexion extension, tensing of the body, usually 4 to 5 to 6 to 10 in a row, and then seems fine. These kids need an urgent EEG and a referral to a tertiary care center for further evaluation and treatment. In the child neurology group, we feel this is a medical emergency and hope that we can diagnose and treat promptly and have a better outcome. I'm not sure that I can say that that's truly what happens, but we try. The most common identified etiology for this, currently anyways, is tuberous sclerosis. And so looking at the child's skin very carefully as you're examining the child for this event in your office is key, because infantile spasms are strongly linked to tuberous sclerosis, and are treated differently actually than other type causes of infantile spasms. If you have a child who's 2 or 3 months of age and has white spots all over their skin, so you think they might actually have tuberous sclerosis, it would be key to refer them promptly to child neurology and genetics, because you can actually screen those children for the onset of infantile spasms, and again, hope that the sooner we diagnose them, the better they'll do. So there's actually a protocol for pre-infantile spasm EEG testing in kids with TS. The next epilepsy, and really one of the most common in childhood, is absence epilepsy. They have a classic EEG with 3 per second spike and wave discharges. These are provoked by hyperventilation. I do have one patient where the family brought in a video of the child with his first, at least recognized, seizure. Probably he'd had more before, but they had gotten burritos and the family had mistakenly given him the spicy burrito. And so he's hyperventilating because his mouth is hot. And so he's sort of blowing in and out because his mouth is on fire from the burrito. And then he stops and stares and blinks and all that. And so it was a way for the family to actually show an event, and it was provoked by hyperventilation unwittingly, of course. It's a pretty common epilepsy of all childhood epilepsies. It's about 12%, so that's a pretty common type of epilepsy, and for some reason occurs more in girls than boys. MRI is normal. If you have this diagnosis based on the EEG and the seminology of the seizures, it's not clear that an MRI is going to help you. And so it's not something to rush into. And the children are usually quite normal and have not fallen behind in school, even though they've been missing 15 seconds periodically throughout the school day. But they do have some higher risk of learning or behavioral differences, so it's worth screening or asking for those. And the differential diagnosis, of course, would be that this is a behavioral event, the child's just staring and not paying attention, or there's an autism diagnosis that hasn't come yet, or ADD, that sort of thing. But the blinking, the automatisms are pretty common in the absence epilepsy, and of course don't occur if the child's just not paying attention. And if the child is less than 4 years of age when this epilepsy occurs, then it is worth following up with genetics, because there are some very rare causes of absence epilepsy in very young children that are associated with genetic diseases that would lead to a different treatment. Just to see the picture is worth 1,000 words. This is the EEG of a child with absence epilepsy, and on the first section, the first 3 seconds, you can see it's a relatively normal background, and then pong, out of the blue come these very high voltage, large spike and slow wave complexes that occur at 3 per second. And during this burst, the child would typically be, if on the video that accompanies the EEG, the child would be staring, maybe chewing or fumbling their fingers, blinking, that sort of thing. And then when it's over, the child is fine. So to treat this, we use ethosuximide, Zerontin, comes as liquid, comes as capsules, and the dosing is up here. There are other medications that will also treat absence epilepsy. About 80% of the kids respond to Zerontin, but that means 20% don't. And so the other medications are listed: Depakote, Lamictal, Topamax. Keppra, which is used for everything under the sun in pediatric neurology, does not treat absence epilepsy well, although 15% of kids will respond to it. The sodium channel drugs do not work for absence epilepsy and actually make it worse. So I guess if you're going to provoke, I guess as a way to provoke these spells, you could give them carbamazepine, but I wouldn't recommend it. About 12% of kids with absence epilepsy will have grand mal seizures. Typically, we let them have one. So you can have one grand mal seizure if you have absence epilepsy, and we'll call you absence epilepsy still. But if you have two, then you don't have pure absence epilepsy anymore, and we need to switch your medication. Ethosuximide does not treat or prevent grand mal seizures. The medicine does have side effects, which are rare, but nonetheless, if they occur, then you've got them. And those typically include stomachache or headache in kids. We don't do any blood monitoring, and you can sometimes fiddle with the dose to deal with those side effects. So if the child has absence epilepsy, the treatment's been going well, they've been seizure-free, then we now say, okay, let's go ahead and try and see if you've outgrown your epilepsy, because that does happen with the majority of kids with absence epilepsy. So typically we repeat the EEG. I usually have the kids miss the dose of medication in the morning of the EEG. So take the dose the night before, don't take your morning dose, go get your EEG done. And then after the EEG is done, take your dose, go back to school, and let's see what happens. If the EEG is normal, then we assume that the medication had diminished enough to not be hiding the spike and wave discharges, and we wean off the medication over a couple months. Sometimes kids with absence epilepsy will actually have abnormal EEGs, even though they've outgrown their epilepsy, but these are no longer the 3 per second spike and slow waves. They're focal sharp waves coming from the temporal and central regions. And so when the EEG report comes back abnormal, don't let your heart sink into your shoes, but instead read the report. And if it says focal sharp waves, then go ahead and have the patient wean off their medication and see how things are. If they still have their 3 per second spike and slow discharges, then we continue the medications for another year or two and reevaluate again. If the kids end up being teenagers and are heading into puberty and still have their absence epilepsy, then they're less likely to outgrow it. It's important to remember that half the patients are going to grow up to have the risk of pregnancy. And so our medicines that we use in childhood often are changed to something else in terms of for the female patients, because you want to make sure you're not prescribing a teratogenic medication, which unfortunately many of the anticonvulsants are. This is Alaska, a surf trip for another kid. Partial onset epilepsy in childhood is the most common. So about half of kids who have childhood epilepsy have partial onset. This can occur at any age, although more likely after the first year of life. And it's more likely to occur if the child has some kind of abnormality of their brain, a brain malformation, congenital injury, traumatic brain injury, something, cerebral palsy as a coexisting condition, that sort of thing. Some of these kids may have had focal febrile seizures earlier in childhood. So even though they were provoked by fever, they were more focal. And so it's worth remembering that those kids may come back to have epilepsy, focal onset epilepsy as they grow up. For these kids, EEG and MRI are always indicated. They have a lower chance of remission, again, because if they have a focal brain abnormality, then that that focality is not going to go away. It's going to be there. And so counseling the family and the child as to the likely retention of the epilepsy diagnosis is important. So again, they can set their expectations, they can learn to take medication regularly, be compliant, and carry on with life. Family history here is relevant, although less helpful in that this is not always, can be, but is rarely a familial type of epilepsy. So if there's a single seizure, we wait and watch, get our evaluation done, get the EEG done, get the MRI done, and then if there's a second seizure, then we go ahead and treat the child with medication. If the first seizure lasts more than 20 minutes, which is our definition of status epilepticus, then we still wait until there's another seizure. It turns out the risk of further seizures after a single episode of status epilepticus is not greater than a short first seizure. So we just wait and see so as to not commit a child to medication unless necessary. The EEG is often not so helpful in that it can be normal in children with partial onset epilepsy, which is sort of irritating, but nonetheless, it doesn't always help you. And it may or may not correlate with findings on the MRI. You may find, white matter abnormality on the right on the MRI, and the EEG says, no, the seizures come from the left. So just to be ready for that, ready to say, well, we know this doesn't always correlate. Typically, we give Keppra as our first-line drug. It has the least side effects, is well tolerated, and has some dose variability. So if there are breakthrough seizures, you can go from a low dose to higher doses. There are side effects, like there are with everything, and these include mood and behavior changes that are worth mentioning to the family, but not necessarily doing something about it until they occur and are problematic. It does typically does not affect the appetite. Moving on to a happier type of epilepsy, benign epilepsy with centrotemporal spikes. These are kids, this used to be called Verlandic epilepsy, and then it was called Beck's, or benign epilepsy with centrotemporal spikes, and more descriptive epilepsy. These are kids who have seizures at night. They're prominent focal seizures. There's often a lot of drooling and confusion afterwards, and they occur during sleep. The kids will sometimes make noises. Sometimes their roommate, their sibling who shares the room, may notice or tell the parents that this is happening, and they're usually pretty short. They don't occur very frequently, although there are some kids who will have them more frequently than others. And when we treat them, because they only occur during sleep, we give them bedtime medications only. So you might, for instance, give Keppra or Tegretol, carbamazepine at bedtime, knowing full well that you're not treating them during the day. And so if they're in the car on a family trip someplace and they doze off in the car and have a seizure during the day during a nap, it's because you're not treating them at that time of the 24 hours. And we'll accept that. We'll say, okay, fine, you've minimized daytime side effects because you're not giving medication during the day, but knowing that you may have an occasional nap-associated seizure. These are typically kids who are school age, and so it's important for families to know that they still have to be watched, and if they go to sleepovers, they need to, again, have the bed away from the wall and those sort of things. As we move into teenagehood, there's juvenile myoclonic epilepsy occurs. This is a very common type of epilepsy with a very strong familial component, so a familial inheritance, and that's autosomal dominant for many of the kids. The autosomal dominance is often difficult to be sure about. I have a family that I cared for many years where the uncle had myoclonic epilepsy. The father, who was a surgeon, did not, and two of his three children did. And he actually asked me, the surgeon said, well, so should I get an EEG? And I was like, oh, no, let's not look. So even though the father was the obligatory carrier, he had not manifested the JME for whatever reason. So these are kids that at the onset of puberty, they either have myoclonus, so sudden jerking of typically the arms and sometimes the head and neck, or actual generalized tonic-clonic seizures. They can also have absence or staring seizures. Sometimes the kids will themselves have the myoclonus and know that they're having it and tell you about it. And so it's important to heed their history. This occurs typically upon awakening. So they might say, you know, when I get up and I go downstairs to get my orange juice, I always spill because my hands are shaking. And that's their early morning myoclonus. Getting an EEG on that child will show that they have a 4 to 6 hertz polyspike and slow wave discharge. It's bilateral. Their MRIs are normal. The kids are often very, very normal. But their chance of remission from this epilepsy is only 20%. And so you're looking very commonly at, you know, for the majority of these kids at lifetime medication. So you're really going to get those kids on board with taking medication, being responsible, maintaining seizure-free, avoiding risk, which again, with teenagers, as we all know, is not so easy. Traditionally, valproate is the right drug for these kids. And the catch with that is that these are teenagers who are going to maintain this epilepsy for lifetime, most likely. And half of them are female. Valproate is our most teratogenic anticonvulsant. The other ones, you know, come in a robust second, but valproate is really the worst. And so for the women in this group, of the girls, you're going to pick something else and hope to goodness that you can get them seizure-free. The other medicines are not as robust in terms of good outcome with seizure freedom in juvenile myoclonic epilepsy, but so Keppra, lamotrigine, Topamax, that sort of thing. And driving and reproduction counseling are warranted at every single visit with these kids, particularly the women. So as I've alluded to, you know, can you outgrow your epilepsy? For many kids, the answer is yes. For febrile seizures, pedimyral epilepsy, certainly. For juvenile myoclonic epilepsy, it's not zero, but it is unlikely. So you just have to counsel them about that. And usually by the time the kids with JME have headed off to the adult neurology clinic, we have investigated as to whether they have, after being seizure-free for a couple of years, whether they have an abnormal EEG still, and whether they're still prone to epilepsy, and sort of hopefully help them sort of reconcile that ongoing risk of epilepsy. And as I said earlier, for other types, it's maybe. So for partial onset epilepsy, which is half of the kids with seizures, only 40% will outgrow their seizures. So you've been seizure-free, you've been taking your medication, compliance has been good. When that compliance, of course, involves the parents, the kid, and anybody else involved in the child's care. I've certainly had families where we made the school in charge of their medication on weekdays, just because the home situation was not maybe so wonderful, and missing morning doses was the name of the game. And so we, you know, involved the school in dosing as well. So you get as creative as you need to be to get these kids seizure-free. And if you have seizures in that time, that 2-year time, what was the circumstance? Was there a head trauma? Was there sleep deprivation? Was there medication non-compliant, which for the teenagers is the most common thing? And you know, figure out what's going on. So, but if you've been seizure-free, then you're going to repeat your EEG, see if it tells you that the epilepsy is still there. Of course, if your EEG was normal to start with, you may not expect that the EEG now will help you, but it might, in that you might actually catch some abnormality or focality if it's a focal epilepsy. And so it's worth doing that EEG to see sort of if you can either get more information or know where you're going. So you've diagnosed epilepsy. You've taken a history, a good family history, really, really key, done a physical exam, skin exam being really an important part of all this, and basic labs, which often include an MRI, but always include an EEG. You try and categorize the epilepsy type and then treat after a second seizure. I think I didn't mention, but in pedimyral epilepsy, by the time you've seen them, they've had more than one seizure. So those kids are pretty easy to treat on the first visit because they've already had, you know, probably 50 to 100 by the time someone notices even. Remember to discuss first aid, both for home and in school. Really work on medication compliance and communication about potential side effects. You'd hate to have a child taking medication that's giving him terrible side effects. So he's actually taking it, but he's having terrible side effects and no one's telling you. And for a lot of families in the day and age that we live in, and probably now that we're post-COVID, even more so now, counseling about the diagnosis of a new chronic medical condition is key to help them embrace their journey and look at this as part of what happens in life, and that they can cope with it. The Epilepsy Foundation in your local community is usually quite active and is a really good resource. Around here, they have support groups where families and teens and younger kids can all join their own individual support group, and there's certainly plenty of activities. Tell me what questions you have. I think we have time for questions. Yes, we do.
Thank you so much, Dr. Hayward. Please feel free to submit your questions into the Q&A, into the chat, or raise your hand and I can unmute you. Any questions at all? Any comments?
Yeah. If somebody had a case, like oh, I saw this kid the other day and da 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 da, you could also ask that here too. That's certainly a good forum for that.
We have a question coming through. Let's give them a minute to type it.
Okay. Yeah, the chat number has changed.
Is there any sport not allowed?
The one sport that I work so hard to dissuade people from, but I have to tell you that there is no form to be filled out, is scuba diving. So if you were to have a seizure 50 feet down with your scuba mouthpiece in your mouth, you would drown. That said, the people who go scuba diving, I've had several patients with epilepsy who already either were engaged in scuba diving or were going to become engaged in scuba diving, and there's no medical permission to fill out, I guess. I think you'd probably just sign your life away, even for minors. Maybe your parents signed your life away. And so there is no really input requested from your medical professional. I do try and dissuade people from that. And most kids don't go skydiving. And so I guess that would be another one to consider for adults, in that if you had a seizure as you were supposed to be pulling the ripcord and opening the parachute, you would be splat on the ground, which would be a bad outcome. Otherwise, there's the old head trauma problem with football and rugby and lacrosse. And so I will ask what sports the kids are involved in and discuss the relative risk of that sport with their epilepsy. Swimming is not contraindicated and the reason being is that when you're swimming as a sport, you're in a pool and the coach is watching you go up and down and saying, oh, you didn't take that stroke right, and you weren't fast enough, and blah blah blah. And so the coach is actually watching you. So I do make sure that the family has notified the coach, so that if there were a sudden sinking to the bottom event, that someone would jump in and get the kid. And I also recommend that the kids not play funny games and have tea parties on the bottom of the pool, as kids sometimes do, because that would be terrifying for the adults involved. Mm-hmm. But again, there are no actual sports that require medical input that are contraindicated.
Thank you. The next question is it a good idea to encourage birth control for teens on anti-seizure meds? Any contraindication?
Yeah.
Yes,
so for sexually active teens, I do recommend birth control if they are taking medication or not. Only in that teen pregnancy is obviously a higher risk than a planned pregnancy. The anticonvulsants and the birth control pills do interact. So depends on, you'd have to look it up and up to date or check with your pharmacist, but many of the sodium channel drugs like carbamazepine, which is used commonly for kids with partial onset epilepsies, many of these medications increase liver metabolism of other medicines like birth control pills. And so the mini dose birth control pills that are most commonly used these days would not necessarily be effective, i.e. might have a breakthrough pregnancy. And so it's important to work with either the pharmacy or the teen adolescent medicines to mix and match the birth control pills with the type of medication that you're prescribing for birth control. For girls with juvenile monoclonic epilepsy, where the only medicine that works for them is valproic acid, which, as I said, is the most teratogenic, I do actually recommend birth control pills and folate. And speaking of folate, all teenage girls who, even if they're not sexually active and aren't taking birth control pills because they don't really need them, they should probably still be prescribed folate because of the risk of spina bifida, cleft lip associated with the teratogenicity of many of these medications. And so that is a newer recommendation. But if there is a girl who I can only give them Depakote, then I do actually recommend that they're on birth control, even if their parents swear they swear they're never going to be sexually active just because of the significant risk of teratogenicity.
Thank you so much. How about driving with seizures?
Well, you shouldn't be having seizures if you're driving. And so for teenagers, so for the most common epilepsy being juvenile monoclonic epilepsy in teenagehood, the girls have had the onset of the epilepsy around 11, 12, 13. So they're not driving yet. So you got them all slam dunk compliant and ready to roll by the time they're able to drive. Many of them, at least in California, you have to report if you're 14 or older if you've had a seizure. So if you have onset of juvenile monoclonic epilepsy at age 12 and you're 2 years seizure free when you're 14, then they're not reported at the DMV. Then they go and drive at 15 and a half. They're not been reported. And so they just go straight through with driving, and they can honestly fill out the form that says, I haven't had a seizure in the last 3 years. So there are kids who will go and get a driver's license, and the DMV has no knowledge of their epilepsy whatsoever because they've been seizure-free long enough. Boys, on the other hand, are the bigger trouble because, well, they're terrible drivers, but anyways. But I had 3 sons, I know this. The onset of their epilepsy is later because puberty starts later. So they started having their seizures around 15. And so by the time they're able to drive at 15 and a half, they're not seizure free. And you're still struggling to work to make sure they're compliant, making sure they're seizure free, making sure, all that stuff is set to go. And so when they do need a driver's license, they've been reported to the DMV already. They have had a seizure in the last 2 years if they are going to go and drive, say, at age 17 or something. And so it's a whole bigger ball of wax for them. And so again, they have to be seizure free. The good news is that a lot of kids these days seem not to want to drive as much. I don't know if, Uber and Lyft have taken care of that problem for us or what the deal is. So a lot of kids seem not to be rushing into driving. On the other hand, the carrot to get them to be compliant is driving. And so that's something that we would use to, sort of say, okay, you really got to take your medication because you really got to be seizure free because you really want to drive, right? So if you have seizures, you can't drive. And most states, as I mentioned on an earlier slide, have different rules in terms of how long you have to be seizure free in order to get your license. California being the land of fruits and nuts, the length of time is a reasonable length of time, whatever that is. And I usually tell my patients it's got to be at least 6 months. So, but anyways, so if you're having seizures, you should not be driving, period.
Thank you. We still have 5 minutes. Are there any other additional questions? Excuse my pronunciation here, but Depo-Provera and anti-seizure meds interaction?
I don't think so. It's a combo that I've certainly had, people use. And so I don't know that there's an interaction. Again, it's more typically the kids that I was treating with Depakote or with valproic acid, which tends not to interact as much with the birth control, pills anyways. But again, it'd be something I would check with the pharmacist depending on what medication the child's actually taking. But yes, again, another good method of birth control.
Thank you. I think that covers all of the questions. Just getting some nice comments. Thank you. This was a great talk. And we still have 4 minutes, so please, anything else?
So I have to say, if you don't know how to notify your local public health department or DMV, it's worth going online and figuring it out, and even printing out at least one copy of whatever form it is that they want filled out, or tagging the website, or however they want their reporting. Because as mandated reporters, it's really, really important that that step of the notification occur. And again, you can't rely that anybody else who's touched the patient previously has done this. It's really, really key.
Well, thank you again so much for your time, Dr. Hayward, and thank you everyone for your patience we got started a few minutes late. And yes, Dr. Williams, the slide deck will be distributed to everybody once this webinar closes, as will the recording. So make sure you fill out your CME surveys, and we'll talk soon.
Great. Thank you so much for coming. I'm sorry I can't see all of you, but in any case, thank you.
Thank you so much.